Hello again. As discussed, we're going to be talking about Chapter 9, benchmarking data in healthcare. Again, basically with benchmarking, we're going to be looking at data, we're going to be reporting it, and of course, making decisions with it. And we do this all the time, some of us without even realizing it. Let's take a look at the closer details on this. We're going to be talking about benchmarking. We're going to talk about the link between benchmarking and value-based purchasing programs, and then we'll be talking about healthcare report cards. Benchmarking is basically comparing the performance to a standard of two similar organizations. So when we do internal benchmarking, we're looking within and we're comparing to internal goals or looking at the same goal year over year. With external benchmarking, we're looking to outside the organization. We're comparing it to some sort of external norm or to competitors. And the reasons we do this, we want to identify areas that healthcare programs, hospitals, practices are strong or weak in, and it's part of the overall quality improvement culture. You'll be talking more about this when you take quality improvement. So there's certain steps we do with benchmarking. First of all, we want to identify the issue to benchmark. This could be something that's set out with Joint Commission like the core measures. It could be pharmacy wait times. It's all different types of things. The important thing is we want to identify an issue to benchmark. Then we want to locate the internal data that's related to the issue. We might get information about internal data with pharmacy wait times from health plan surveys and so on. Then we want to analyze it. We want to analyze the internal data. How are we doing both ourselves internally when we're looking at how we do over a period of time? And then we want to see how we're comparing to national standards or to our competitors. And then we want to identify external data that's available for benchmarking and collect public domain or purchase data if it's applicable. Like, for instance, different healthcare insurance companies do this, where they look at data that's given out by CMS or the Society for Thoracic Surgeons and so on, and kind of compare. Then we compare this internal and external data. We determine whether a performance gap exists, and then we communicate these, and then we come up with performance level targets and action plans for achievement. If we're falling short, we'll want to have an action plan on how we're going to address those issues. If we're not falling short, we want to have a plan on how we're going to maintain these gains or perhaps even improve more. Then we implement plans, we monitor and communicate progress. Then as things change, we want to recalibrate benchmarks as necessary. We saw a lot of this with the COVID-19 dashboards and so on. Then basically want to repeat the process. And this is a theme that you'll hear about in quality improvement. We do benchmarking, we collect data, we see how we're doing, we analyze, we act, and then we repeat the process in order to have continuous quality improvement. The hospital value-based purchasing program is an example of this. This is formal benchmarking, and it has 4 domains. CMS is interested in what is your process of care, what are your outcomes of said care, what is the patient experience, and how efficient are you in this care? And then it generates total performance scores that are used to determine incentive payments added to Medicare inpatient payments for participating hospitals. So basically what this is doing is putting a certain amount of the hospital's revenue at risk. If you meet all these quality goals, if you have a high enough total performance score, then you get more money. And a way to communicate how we're doing on these benchmarking things is dashboards and scorecards. And you can see some examples of those in your text. Let's take a look at those now. And here's figure 9.2 in your text. And this talks about variation in standardized Medicare patients. And again, these get enhanced in things like Tableau and so on. And you can click on a state and get more finer level detail. And with this, we have clinical, operation, and financial categories built in. And again, our dashboard, as we saw just a little bit ago, cost per state, how this state compares to the nation, difference to the nation, and so on. A lot of interest in these going on, and we'll see more of these in the years to come with even more data being collected. Another area that Medicare is especially interested in is chronic conditions. This is reflected in the HCC reimbursement model that some of you are familiar with from your time in the reimbursement class. And this is talking about the per capita Medicare spending. So in other words, if a patient has 6 or more chronic conditions, they're spending a lot more per capita than if they had 0 to 1. And something else you hear about a lot in healthcare operations and health information management is the National Quality Forum. This provides a framework for endorsing quality measures by having working groups that look at important measures in quality improvement in both public and private sector health. They build consensus for performance measurement, and they seek real feedback to ensure that these measures are meaningful and accurate. The important thing to bear in mind is a lot of this data, that these measures, if you will, come from the electronic health records. So as we've transitioned from paper-based records to electronic health records, now we can collect more and more data and do these types of dashboards, share information, and do benchmarking in a much quicker, more effective manner. And something else that we do is you can now compare. Going to data, Medicare.gov, you can compare hospitals, nursing homes, physicians, home health, dialysis centers, and more. And similar to the COVID website, you can look at these things at a fine level of detail, bearing in mind, however, that these are only Medicare quality measures. And here's an example of one. We're looking at Northwestern Memorial, Providence Hospital of Chicago, Rush University Medical Center. We're looking at an average, and the measure is as follows. Outpatients who having surgery who got an antibiotic at the right time within 1 hour before surgery. And again, this is important in terms of post-op infections, so on. So you can see how all these hospitals compare. Ideally, these quality measures should include an adjustment for the risk of an adverse outcome. So in other words, if the one hospital is got a service population that has sicker patients, you would expect that their scores would be a little bit different than other hospitals. There are other things, the gender, the age, comorbidities, who has insurance, social determinants of health. And on the provider level, is the hospital a teaching hospital with interns, residents, and fellows? Is the location urban or rural? What are the social economics attributes of the patient mix? So again, tying into the social determinants of healthcare, the payer mix, and so on. So a lot of interest in this term risk adjustment. In other words, how we can look at this and make sure that we're comparing apples to apples. So here is another one, and rather than read things directly from the slides, let's look at what this means. This is central line associated bloodstream infections. So obviously lower percentages closer to 0 would be better. So you see Cleveland Clinic has more. They're almost at 1 at 0.899, right, percent. Ohio as a whole is 0.683, and then we have the other hospitals displayed. So one of the things that Cleveland Clinic may be able to argue, and I haven't looked at their data, so I can't say for sure, but are they dealing with a sicker population, right? So again, when we look at these dashboards, we look at these things right here in graphs, it doesn't necessarily tell the whole story. You need the whole context of the picture in order to really make meaningful conclusions. And that's all I have for you. We'll see you online. Please stop by office hours if you have any questions about this material. Bye now.